Okay, so in this section, we're basically going to talk about basal ganglia disorders. So if you remember, the basal ganglia is a part of the brain that really has a control of gating the thalamus, gating function. So it calms down certain areas. When people have PANDAS or PANS, they get obsessive compulsive disorder, they get hyperkinetic movements, vocal tics, motor tics, Tourette syndrome. So we're really going to focus on these childhood developmental disorders and injuries to the brain that take place from infection involving the basal ganglia. So let's do a deep dive into that. So my academic goals of this presentation is to review the pathophysiology of obsessive compulsive disorder, Tourette's, tics, and hyperkinetic movements. And then we're going to review the pathophysiology of PANDAS, which stands for Pediatric Acute Onset Neuropsychiatric Disorder associated with Streptococcus syndrome. And basically, it's a, if you're not familiar with PANDAS, it's a pattern where children get a Streptococcus infection, like strep throat, and then the infection creates antibodies that then cross-react with the basal ganglia, and it causes acute neuropsychiatrics for them. So the very next day, there's behavioral changes in the child. So hence the acute onset. And then if it's not Streptococcus that causes the infection, then it's called PANS. So we're going to review the pathophysiology of pediatric acute onset neuropsychiatric syndrome, which is the same thing, but not specific to Streptococcus. Then we'll review the diagnosis and clinical management considerations for basal ganglia disorders, and then talk about a step-by-step approach and some issues that take place when it comes to working through and providing clinical strategies to help these kids that are in these patterns. Okay, so let's go over to the basal ganglia first. It's the basal ganglia neurology. So when you look at the brain, you can't really see the basal ganglia from the outer surface, right? So the basal ganglia is deep, really in the center, in the middle of the brain, right? So here you can see the cerebral cortex and the cerebellum, but as you get deeper into the brain, here you can see areas of the basal ganglia that and the limbic system that's involved here. But here is even a better slice. Here you can see this is the brain cut, a coronal slice. And right here, you'll see the thalamus. So remember, everything comes, all the input we have goes directly into the thalamus. And here you can see, like an illustration, auditory, visual, proprioception, taste, olfaction, muscle, spindle movement, vestibular input that goes in the cerebellum. They all eventually hit the thalamus, and the thalamus activates all the different regions of the cortex. Well, the basal ganglia has pathways that inhibit the thalamus and also excite the thalamus. So the basal ganglia has what's called the direct pathway and an indirect pathway. And the direct pathway increases activation to the thalamus, and the indirect pathway inhibits activation of the thalamus. So this is why it's called it's a gate. It gates the thalamus. And it's kind of like a checks and balance system from us being overstimulated. But the basal ganglia indirect pathway is really the pathway that inhibits and calms down the thalamus. And when you look at things like Tourette syndrome and motor tics and obsessive compulsive disorder, the injury is to the basal ganglia, and the basal ganglia can't gate the thalamus. So then you get these spontaneous emotional responses, rotational movement responses, and so forth. So that's what I want to really illustrate here. So here you can see the same thing. Brains, you can see input coming in from here, the cerebellum into the thalamus, but the basal ganglia indirect pathway can gate some of that input. It's normal and necessary for the basal ganglia to inhibit all these inputs coming into the thalamus. And here you can see the direct and indirect pathway. The indirect pathway, this blue line, inhibits activity to the thalamus. That's important. So you can see that this direct relational loop. And here you can see, again, the cortex, basal ganglia, indirect, but globus pallidus interna here, inhibiting thalamic projection. So it calms down, it gates the thalamus. So when we look at this function of the basal ganglia disorders, and the other thing I want to point out actually is if you see the cortex fires into the basal ganglia, and specifically the frontal lobe. So the frontal lobe fires to the basal ganglia gates the thalamus. So that's the key mechanism there. So when you look at this functional basal ganglia pathways, the frontal lobe activates the basal ganglia. The basal ganglia here you can see in blue. The basal ganglia surrounds the thalamus, and it gates, excites or inhibits. The internal pathway inhibits the thalamus. And then there's different loops within this basal ganglia, there's the limbic loop, and the basal ganglia inhibitory pathways on the limbic loop control anxiety, rage, anger, violence, and compulsiveness. So that's the function there. And then the motor loop controls motor movements to be smooth and under voluntary control, so they're not spontaneous and firing out on their own. So this is basal ganglia functions. So the frontal cortex activates the basal ganglia. Basal ganglia can gate these patterns. And for our concerns today, we're worried about these basal ganglia disorders is the indirect pathway, which inhibits these limbic responses and controls anxiety, and these motor pathways that control hyperkinetic movement. So one of the things you have to know is there's lack of frontal lobe development or fatigue of the brain. Like we talked about this with children that are suffering from autism. They have like anxiety and violent and compulsiveness and these types of behaviors. If their brain, especially the frontal lobe, gets fatigued, then you get inability to activate the basal ganglia. And if you can't activate the basal ganglia, you have inability to gate the thalamus. And then if you can't gate the thalamus in the limbic loop, you start to get impulsivity and hyperactivity, OCD, anxiety, anger, rage. And if you can't gate it in the motor loop, you get vocal or motor tics. This desired impulse to have to clear the throat or move or blink the eyes or whatever the individual person's motor tic or vocal tic may be. So this is an important pathway. So this is where, and for example, some children that are suffering from attention deficit hyperactivity disorder, ADHD, their frontal lobes are not really completely developed. They're not efficient. They're not getting proper epinephrine, norepinephrine, dopamine responses. They can't activate the basal ganglia. The reason they get hyperactivity is because they can't gate their limbic loop. They have a strong relationship with their limbic loop, and they got impulsivity and hyperactivity. With children that have autism and their brain gets fatigued, and especially when their frontal lobe gets fatigued, they can't gate their thalamus and then get anxiety, rage, anger, and so forth. So this is a very important pathway. So the frontal lobe activates the basal ganglia gates these thalamic pathways. So when we see hyperactivity and impulsivity in a kid, therapeutically we're trying to get that frontal lobe to become healthier. Now, another pathway, this is where PANDAS comes in and PANS comes in, where infections can cause acute neuropsychiatric symptoms, is when there's direct injury to the basal ganglia itself. And this can happen through cross-reactivity or molecular mimicry. So antibodies formed against pathogens, like Streptococcus, have protein amino acid similarity to structures in the brain, in the basal ganglia, on dopamine receptors and other basal ganglia receptors, that those antibodies against the infection, if the blood-brain barrier is permeable, can then cross into the brain and then cause injury to the brain itself. So another mechanism for anxiety and tics and compulsiveness is that the basal ganglia is injured from the antibody cross-reactivity response, so that also leads to inability to gate the thalamus. So then you have this acute onset of tics, motor tics, vocal tics, anger, rage, changes in behavior, hyperactivity that takes place. And that's the concept of acute onset neuropsychiatric symptoms. The acute onset neuropsychiatric symptoms is injury to the basal ganglia from an infection that then leads to loss of these limbic loops. And if they have motor responses and tics, then through the motor loops that then present clinically. So that's what you need to know as we get into the material. So once more time. So the frontal lobe activates the basal ganglia. The basal ganglia indirect pathway inhibits the limbic loop and motor loop. And whether the frontal lobe is not functioning well or the basal ganglia is not functioning well, there's this inability to dampen these loops that then lead into impulsivity and compulsiveness and OCD and hyperkinetic movement disorders. Okay, let's get into showing you some of these. Let's talk about hyperkinetic movement disorders first, that motor loop first. So this is the basal ganglia pathway again. Here you can see the thalamus, and these are the basal ganglia structures, and there's projections from the cortex to this. Those are called frontostriatal projections. So the globus pallidus, interna, externa, and the striatum here. These are known as the striatal pathway. So you can see frontostriatal projections all the time if you read papers. Those are the inputs from the frontal cortex to the striatum, to the basal ganglia. So those frontal striatal projections activate the basal ganglia. The basal ganglia then has projections to inhibit the thalamus. And here you can see a motor circuit where the motor cortex is involved here, an association circuit, and then a limbic circuit where the emotional pathways are involved. So these are all gated in that pathway. So we want to look at this motor circuit first, this association motor and motor circuit together that the basal ganglia has to dampen. And this is where vocal tics and motor tics come in, right? So vocal tics and motor tics can be simple or complex. And they're, as far as the diagnostic criteria, it's considered a provisional tic disorder if it's less than 1 year. It's called a persistent motor vocal disorder if it's more than 1 year. And if it's both vocal and motor, then it's Tourette syndrome. Then you can have variabilities in between these, but that's a diagnostic criteria. And we went over and showed some examples of each. Let's just review those again. So these are simple motor tics. This is the basal ganglia motor loop not working. So you could have a person like this child get an infection, boom, overnight. They can have tics. Or their frontal lobe just isn't developing, so they can't activate the basal ganglia pathway. And those motor tics are there. Okay. So these aren't mysterious. Like when we see these, as soon as I see this as a clinician, I'm going, the basal ganglia indirect pathway motor loop is not working. Is it because the basal ganglia is injured, or is it because the frontal lobe is not working? That would be my first initial thought. And you should think the same way when you see these types of tics. Now, if the motor loop involves multiple areas of the brain, then you have more than one muscle group involved, and then you get more of a complex motor tic, where you have more than one group involved. Now, the key thing is, if this happened immediately, boom, overnight, you have to think of infection. Any kind of acute onset to any brain or neurological symptom, you either have to think infection or vascular, like a stroke. Well, kids don't get strokes, so kids more likely are involved with infection. Like if it's happened in a senior and adult that all of a sudden had motor tics, I would think they probably had a microvascular or some type of mini stroke, and then this is an acute onset and it involved the basal ganglia indirect pathway, right? And those are lenticulostriatal vascular projections and mini microvascular strokes. But in children, when you have overnight motor tics, then you have to think that there was probably some acute injury to the basal ganglia. And then there's people that have more complex genetic or disorders that may lead to Tourette syndrome, or they can get infections and injuries that relate to Tourette syndrome, and that's where you have severe disability with some people, like this person here, has got severe patterns, both motor and vocal tics.
Tell me again about how long all this is.
And the key thing is, just as a review, is that these are basic ganglionic. Now, like this, but then you have children that don't have an acute onset. They just, throughout their childhood, they've always had that parents call it personality, where they always have to clear their throat or do things. Those are frontal lobes that aren't developed properly. And it wouldn't be a surprise to you as a clinician. They also had ADHD, because ADHD is associated with frontal lobe development. But here's an example. Here you can see him. See those motor tics? The vocal tic, that clearing. So if I saw the child walk in my office, I would immediately think their frontal lobe is not developed. And if it was acute onset, then I would start to think about PANDAS pants. So those are the things to take away. And then if it involves more complex motor system injury, then you're thinking of more complex motor system.
I love the American bacon. It's like, oh no, I don't like it.
Right? Now, with some children, as they're developing, they have some motor tics because their brain is just, it's normal. Like some kids will have some motor tics for a second as their brain develops, and then they kind of grow through it. It's just their development. So they're not always a total cause for concern. They're concerned if they persist, but it's not a problem to see some motor tics in the initial stages. But it's, to me, at that point, I still want to go, hey, what are they doing? What are you feeding him? What's their brain stimulation like? What's happening with them? Maybe like, hey, you know what? Why don't you just try to, like, do the diet history, and they're drinking milk every morning with cereal, then they're having cheese all day, then they have mac and cheese for dinner or pizza, and like all they're doing is eating dairy and milk. And you go, hey, let's try, get them off dairy for a couple of weeks, see what happens. And then like 2 weeks, maybe all their tics and motor patterns go away because the inflammation was getting in the way of their neurodevelopment, right? So sometimes as simple as that, it's not a complex neurological disorder. It's just those pathways are impacting that frontal striatal projection that gates the thalamus, and sometimes they present that way. Okay, then you get OCD, and then OCD is these basic ganglionic circuits, but it's not impacting the motor circuit. It's impacting the limbic circuit over here. So this limbic circuit, what's involved? And this limbic circuit, has these pathways that also, again, gate the thalamus, different projections there. This is the paper in your notes about basal ganglia, OCD type specificity. And when the limbic loop gets involved, it's not a motor tic, but it's this obsessiveness, compulsiveness, anxiety, and fear with the basal ganglia pathways. So reoccurring unwanted persistent thoughts, images, urges that cause marked distress, compulsiveness, repetitive behaviors, mental acts that are often driven by rigid rules, washing, cleaning, checking, reassurance seeking, repeating, contamination, aggressive harm, sexual is not really common with kids, religiousness, making things just right, but these are common things. Now there's some adults that have OCD and they'll do things like, I have to go for a run to control my OCD. So what are they doing when they go for a run? They're stimulating the hell out of their frontal lobe. They're activating motor movement, they're getting blood flow there, they're getting cortical activation of that cortical striatal projection, and then all their OCD symptoms start to calm down, right? And same with some kids. They need to really get their brain to function and fire to have some patterns. So when frontal lobes don't develop well, they can't activate that frontostriatal projection to the basal ganglia. They can't dampen that limbic loop of that basal ganglia pathway, and they can get OCD type behaviors. Now, if it happens overnight and acutely, you think of things like PANDAS and PANS. And if it's just there and it hasn't been overnight and it's just developing, you start to think about the frontal lobe. And, most common questions to ask as a screen: do you wash or clean a lot? Do you check things a lot? Is there any that keeps bothering you? Do you have daily activities that take a long time to finish? Are you concerned about putting things in special order? These problems trouble you? Those are the basic symptoms for OCD. And you have to understand OCD is not just, and anxiety is not just this pathway. This is just in reference to childhood developmental disorders. We have an entire course that's coming up on mood disorders, and there's multiple pathways for anxiety and OCD, not just the basic ganglia. But for children, when we look at development, it's really when their frontal lobes are not developed or their basic ganglia gets injuries where these things really start to come out. Now, you can have children with autism that have white matter tract lesions in the pathways from the basal ganglia, so they don't have an acute onset, but since they're not having proper white matter tract pathways that impact basal ganglia, they can have OCD type behavior as well. And it's not necessarily related to the frontal lobe not functioning or working well, it's just those tract pathways that are involved. And then here you can see the neurocircuitry of OCD that was published in this paper, but it's basically the frontal cortex, activating the frontal cortex members involved with decision-making, planning, conflict evaluation, and so forth. So if you see kids that have executive function, they can't plan, they can't organize, they can't stay on track, they can't stay on time, and they have OCD, then their frontal lobe may not really be activating that pathway. And then it just kind of goes through the circuits, but ultimately these pathways impact the thalamic projections. So this is a paper that was published. It was titled Cognitive Inflexibility in OCD Disorders. So this article found, and this was shown in a pediatric population, and actually, let's go over this first. Cognitive inflexibility. So one of the things that happens with children have PANDAS and PANS overnight is they will not be able to make any decisions. They're stuck on their way. They become defiant. They become resistant. They're totally convinced that they're going to get injured if something happens to them if they eat a certain food. This is part of the brain firing in the frontal cortex. Normally, if you have something that's unreasonable, like if I eat this food, I'm going to die. If you go outside, someone's going to get hurt. Or if I walk upstairs alone, there's something bad's going to happen to me. Normally, you would have maybe that initial thought. And we have those thoughts at a given time, all the time in our normal brains. But then our frontal lobe kicks in and goes, no, nothing's going to happen to you when you go upstairs. And you can reason through it and think through it and everything calms down. So that's the frontal striatal projection. So that's what's impaired. So normally when you have some of these thoughts, your frontal striatal projections immediately inhibits them. And this is the issue that happens with these patterns. Okay. Now, this was the paper that was titled, "Should Pediatricians Investigate the Symptoms of OCD in Children with Feeding Difficulties?" So the articles found show that there are some common characteristics in the behavior of selective OCD patients. The selective ones reject food that had been mixed or previously touched by someone, food that had touched a plate, and additionally they were repulsed by certain textures. And that's more of a sensory issue than anything else. There are common symptoms between OCD and adults, such as inflexibility, anxiety, rigid behavior, food choices, specific characteristics, color, smell, and textures. So if the frontal lobes becomes more efficient in children that don't have like PANDAS PANS, you can sometimes see some nice change with those patterns. And when you look at basal ganglia dysfunction, here you can see OCD, Tourette's, that also commonly have substance abuse to really get their brain to calm down, compulsive eating, behavioral gambling, these are involved. But that compulsivity is part of the basal ganglia patterns of dysfunction. And here you can see when they look at goal-oriented habits and tasks with people, there's time spent, and you can see this linear response to how things gradually improve. With OCD, they just have to focus on something. They can't get their mind off it. And it can be very fatiguing for everyone involved, the whole family and so forth. But here you see some projections from these are the frontal striatal projections in OCD, frontal cortex firing into the striatum, the basal ganglia. That frontal striatal projection is really what's not kicking in. And here you can see the orbital frontal areas that are activating, but the brain can't stop them, so they get fear and avoidance and the symptoms associated with that. So, the key thing with OCD is they have failure in a top-down control of cognitive inflexibility. They can't, in order for you to have flexibility, when you think something that is horrifying or terrible, it causes fear, your frontal lobe has to be able to dampen that, to be flexible, to then move on. So the frontal striatal pathways aren't working, so there's this cognitive inflexibility. Imbalance in habit of goal-directed system, and they just have to be compulsive and do things even if it doesn't make any sense and waste a lot of time. And then emotional vulnerability, the anxiety and depression typically go together as well because the frontal lobe is involved with depression. So OCD, you can see, is has overlap between things like body dysmorphic syndrome and autism and Tourette's and so forth. I found this video I thought very useful. It really explains, like in a very simple fashion, the sensation of someone dealing with compulsiveness. So I'm going to play this for you.
Hi, my name is Naomi. Ballet is my absolute favorite thing in the world, but a condition called obsessive compulsive disorder put my dreams of dance on hold. My obsessive compulsive disorder, or OCD, started when I was in junior high. I started to get totally stressed out by the order of things. I was fixated on making sure everything was put in the perfectly right place all the time. I felt that I had to do it, like I had no choice. I knew that what I was doing didn't make any sense and that I should just stop doing it, but whenever I tried to stop, something took over in my brain and I just had to keep going. But that wasn't all. I also had these very upsetting pictures in my mind, like dreams, but I was awake. They were images of terrible things happening as a result of a mistake I made. I saw my grandparents being murdered by an intruder who entered the house through a door I left unlocked. I became convinced that I was going to cause some life-ending event as a result of my carelessness. These thoughts and images were obsessions. People with OCD have all different types of obsessions. The important thing to know is that the obsessions are unwanted, intrusive, and repetitive thoughts or images, and that the person experiencing them knows they are unreasonable and excessive. Leaving my apartment for school in the morning was a nightmare. As soon as I closed the door, the images and thoughts started. What if I left my curling iron on? What if I didn't lock the door? Something terrible will happen. My family will be hurt. It will be my fault. I have to go back and check. It felt terrible, and I was almost always late for school.
Are you for real right now?
The obsessions created so much fear and anxiety for me that I had to do something to make myself feel better. I was afraid to tell my friend what was happening in my head. I didn't want her to think I was losing my mind. The obsessions kept building and building until I couldn't stand it anymore. I didn't know what to do, and to make it worse, compulsions began. A compulsion is something you do to reduce the stress caused by a feeling that things just aren't right. To get rid of that feeling, you need to do something, like touching, counting, or chanting. The compulsion makes you feel relief for a short time, but before you know it, the obsessions are creating anxiety again. That brings back the compulsions. It feels like it's never going to end. Just like with obsessions, people have all kinds of compulsions. Remember, a compulsion is what the person does to get relief from the anxiety the obsessions create. One of my compulsions was ordering. There was a time when I stopped going to school because I would spend 5 or 6 hours in my bathroom or kitchen making sure things were in their correct place. It's so hard to explain in words, but I felt like if I didn't arrange these things that something terrible would happen. As soon as I walked away, the overwhelming stress would drive me back to repeat the same thing again.
Okay, so one of the things to understand is the compulsiveness is to deal with the anxiety. So if you see all of a sudden everything is stacked, everything is clean, everything is in order, then they know their anxiety is really flaring up more. And listen, you have to understand that with OCD, like this impulsiveness, anxiety, like there's periods of time where everyone has those patterns. And maybe when their brain's really tired, sometimes people will have those patterns and have some episodes of that, or they're in a lot of stress and lots of things are combining, fatiguing the brain in these pathways, those things can come out. The difference is that with like OCD that's diagnosable, this is happening on an ongoing basis, right? And with children, you have to realize their brains are developing at different stages. It's not even abnormal for them to have some periods where they have a little bit of OCD tendencies. And usually you'll see it with them, especially when they stop moving. And like it's rainy, it's been like raining and haven't gone outside and been doing things. A lot of times OCD comes out and then they start to move again and they totally go away. And then they develop and it's not an issue. But for some people, especially with developmental delays, they don't grow out of it. It just persists and it's an ongoing thing. And it can transition into adulthood, especially if you miss those windows of opportunity to develop plasticity in those frontal striatal projections. And if they happen overnight, in acute onset, that's when you're always thinking again of things like infection. Let me show you this great video, example of OCD behavior in this beautiful 3-year-old child, super cute. You can see a real life example.
This is Raphael. He's been diagnosed with OCD. Here is one example.
I told you to open this.
I did open it.
No, you didn't.
It's open.
No, it's not.
This is open. Look, it's open. There's chocolate putty right there.
Look, this is not open.
You mean this right here?
No, right here.
Right here?
Yeah,
You want me to take this off?
this off.
This.
Yeah.
Are you gonna be able to eat it if I don't take it off?
You did take it off. You can.
It's completely open, Raphael. You can eat it.
Not yet.
Yes,
See,
yes,
this is
yes, you can eat. No, you can eat it right now.
not yet. See, this is shut.
No. Look,
Don't pick it out. You're not gonna pick it out.
it's open. If it wasn't open, I wouldn't be able to get it.
You're not gonna do that in the chocolate pudding.
Look,
No,
look.
you don't do that in the chocolate pudding.
Get your spoon and put it in there.
I got it.
Yeah. Okay, now eat it.
Not yet. After I open
But
this.
honey, it's open. There's nothing there. Look on the other side. Look underneath of it. See, there's nothing here. It's a lip. You could cut it off and it wouldn't matter because your chocolate putty is in the middle, see?
Yeah. You
You're
don't
violating my
do that in the
finger.
chocolate pudding, I said.
Well, you're violating my finger there. Okay, go ahead and eat your chocolate putty.
You don't do that in the chocolate pudding.
Well, his anxiety is very real and his anger is very real. So he's having a hard time processing this information. That the mother is doing a wonderful job because the mother is actually making his frontal lobe fire. So it's actually therapeutic, right? Some people have very severe OCD. You can't do that. There's no chance. But in a scenario like this, by the way, he does actually sit down and eat the pudding. His frontal striatal projection does kick in at some point. to activate that it's actually okay to eat the pudding even though the lid's not completely open. And as the mother keeps doing that with him, it's developing those frontal striatal projection, getting his frontal lobe to work. But this is, an example of OCD and type patterns. So that's one of the things you see with the basal ganglia involvement. Remember, we're going to focus on the basal ganglia in this section. When the limbic loop is being involved, and then hyperkinetic movements like vocal tics and motor tics involved when the motor loop is being developed. And like I was saying before, with children as they develop, normally, sometimes they will have a little bit of a motor tic, maybe even a little bit of vocal tic, but the key thing is that they grow out of it. And the other key thing to remember is that if it's persist and it's ongoing and there hasn't been acute onset, the most likely mechanism to look at is a frontal lobe. And if they have frontal lobe issues, focus, attention, planning, organizing may also be involved. So that may fit the pattern of ADHD as well. And if it's not ADHD and if it's acute onset, then that's when you think about PANDAS and PANS. So let's talk about PANDAS and PANS. So the scenario in these mechanisms are there's an infection. And this is scary, because let me just stop right here. The timeline of PANDAS is a child that has no patterns and issues with any kind of childhood development, and then overnight develops neuropsychiatric symptoms. Sometimes the neuropsychiatric symptoms are severe, where kids literally will jump out of a moving car, or start injuring themselves, or start attacking people in their family, or start cutting themselves. They just become a cutter overnight. They yell. They may even cause injury to themselves, or they just could be a little bit more minor, where they just have some type of anxiety and nervousness, and they can't stop it, or they start to develop motor tics and vocal tics just overnight. And this is because of an infection that takes place. Now, you have to realize not all kids that have infections have this develop. So there's variables we don't understand. But one of the key variables is a breached blood-brain barrier, because these antibodies can only cross into the brain if the blood-brain barrier is permeable. So, we're experiencing this understanding in the healthcare system that actually things like leaky gut do exist and intestinal permeability do exist, mainly because of the research being published through major universities and the discovery of zonulin, a lot of work done by Fasano and his team and other researchers that have published a lot looking at how common intestinal permeability is. I think as time goes on, we're going to definitely see blood-brain barrier permeability be recognized as a serious issue as well. So lots of people have chronic inflammation and oxidative stress, and their blood-brain barriers become permeable. And we know with gut permeability, people develop food sensitivities and start to have systemic inflammation. With blood-brain permeability, people also have very subtle symptoms like brain fatigue, and their nerve conductors and nerve speed comes down, like brain fog. They can't focus, they can't concentrate. Those are all signs that there may be permeability of the blood-brain barrier. And now we know we can test it with lab markers like S100B and blood-brain barrier protein. So I think over time we'll see that blood-brain permeability is very, very common. We published a study 2 years ago in the International Journal of Molecular Science, where we looked at patients that had intestinal permeability, and we wanted to see how many of them had blood-brain barrier permeability. And it was, we looked at association and risk factors, and there was like a 15-fold increased risk of having blood-brain barrier permeability if you had intestinal permeability. Other research have shown the same thing. So zonulin, which opens up the tight junctions of the gut, also opens up the blood-brain barrier. So some of these children that are having blood-brain barrier permeability issues may really be having gut barrier permeability issues, and those are opening up as a consequence of that. Or we know there's people that have gluten sensitivity with the zonulin release patterns that not only open up the gut barrier, but open up the blood-brain barrier. But one of the key things is that antibodies are only crossing when the blood-brain barrier is permeable. So just that variable alone is why some children that get infections develop PANDAS and some children don't. Now, probably isn't just the blood-brain permeability itself. There's probably other variables that are involved. no one really knows what those are, but there is a clear pattern of infection getting into producing antibodies. And then it's not the infection that gets into the brain, it's the antibodies that get into the brain. So with acute neuropsychiatric symptoms, if the infection is streptococcus, then that's the classical model that was first discovered, pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. Autoimmune because antibodies are being produced to attack self-tissue. And then non-streptococcus is now just being termed pediatric acute onset neuropsychiatric syndrome because it could be any kind of pathogen that produces antibodies that cross-react with the brain. So a recent paper we published in the journal, Frontier Journal of Immunology, is we found that spike protein antibodies of SARS-CoV-2 and nuclear membrane protein antibodies and membrane protein antibodies cross-react with the brain. So it's very likely that we may see some PANDAS patterns with some people that end up with SARS-CoV-2 infection. So a lot of viruses have the ability to do that, but the blood-brain barrier has to be permeable. And I would guess myself that many of these long COVID patterns and many people that end up with, for example, COVID and end up with neuropsychiatric symptoms, especially overnight or neurological symptoms, may have some of these cross-reactivity patterns. Now, with PANDAS and PANDAS, the symptoms are specific to injury and cross-reactivity with the basal ganglia. So that it leads to the OCD patterns and tics. It's not all areas of the brain, but it's specific to the basal ganglia. That's where these come in. So that's where they have tic disorders, vocal tics, motor tics, and OCD type behavior and anxiety. So here you can see an illustration of this here. So this is the pathophysiology of let's say PANDAS, PANS, and CANS. So here you see an infection. And then the infection, your host factors, neural antibodies are produced. Those neural antibodies then cross into the brain. They cross-react with the basal ganglia, and that they develop symptoms of OCD and tics. And it's that cross-reactive pattern. And here you can see, some of the hypothesis that's happening. And one of them is like, there's some of abnormal adaptive immunity or abnormal innate immunity. There's loss of immune tolerance. So that's another variable. Their blood-brain barriers are breached and their immune tolerance is impaired. Immune tolerance is their ability to modulate an infection with healthy regulatory T cells or not have overactive T cells. We talk about immune tolerance a lot in the cross-reactive autoimmune course. But if they have an loss of immune tolerance is also what leads to autoimmune disease. So if they have loss of immune tolerance, and combining blood-brain barrier, the combination of this abnormal, innate, and adaptive immunity, it may be what's then leading to these PANDAS or PANS types of patterns. So it's not just the infection. Here you can see another illustration of this published in Nature Immunology. Group A Streptococcus strains come in, molecular mimicry, the amino acid sequence. Again, Streptococcus is very similar to anti-dopamine receptors. So antibodies made against Streptococcus can also bind to anti-dopamine receptors. And these autoimmune target proteins like antiolingoganglioside, antitubulin, antialonase, these are all similar in amino acid sequence to Streptococcus. So those antibodies get made and they can cross into the brain. Then you have cross-reactive changes and you can get behavioral changes and hyperkinetic movement disorders. So this so-called autoimmune encephalopathy is really when antibodies form against the brain. And with PANDAS and PANS, they directly impact the basal ganglia, leading to tics, OCD, and eating disorders. So let's talk about PANDAS first. So it starts out with strep throat. Hey, my throat hurts. It's really itchy. It's swollen. And then, you can see here, pharyngitis. The pharyngeal muscles are inflamed. Here you can see examples of really severe strep infections. But just to illustrate the point, they get a strep infection, so then they have symptoms of pharyngitis, throat pain that develops quickly, painful swallowing, possible fever, and then they have red and swollen tonsils with white patches and streaks of pus. That's your typical strep throat. And then, they can be tested. Rapid antigen tests in the office can quickly check these in most clinics. PCR test or throat swabs can be done. Throat culture can be done to look at the strep. Antibodies to strep can be tested. Anti-streptococcus O or anti-streptococcal D DNA speak can be done. You have antibiotics and you gargle with salt water. Severe cases, you can get rheumatic fever and different presentations of that and joint pain. And most of the time when people develop strep, they can do these home strep tests. These are just like home COVID tests people use. And these antibodies can be measured pretty quickly and very effectively. So that's your typical PANDAS pattern. Now, one of the things is if a kid has immediate onset of neuropsychiatric symptoms and they see these streptomycin antibodies. So these antibodies here, streptomycin antibodies, these are the antibodies. They can be elevated even a year after the initial infection, so you have to be careful with that. But these are the antibodies that cross-react with the basic ganglia. Anti-DNA B streptococcal antibodies, these go up in stress infections, and these are the antibodies that cross-react with the basal ganglia. And when you're looking at these anti-DNA streptococcal infections, realize that you have to look at, despite what the lab range is, you want to look at their age to give you some clues, because 1 to 6 year old, it should be less than 78. So here the range is 0 to 120. So this is the reference interval. Most labs will give you an age reference as well. So make sure you look at that age reference specificity, not just the total reference range. But when they get streptococcal infection, these anti-streptolysin antibodies get formed as a normal immune response. Anti-DNA strep antibodies get formed. These are antibodies that attach the proteins on the pathogen to destroy it. But if you can see here, the blood-brain barrier is permeable, and they probably have loss of immune tolerance. They cross-react against the basic ganglia. These are target proteins, and they get acute neuropsychiatric symptoms called PANDAS. And here you can see another paper that illustrates this D1, D2 receptor autoimmunity. So antibodies directed against D1, D2 dopamine receptors, lysoganglioside, and CMK2 activation, which is an immune response against these patterns. So that's all part of the whole PANDAS scenario. So let me show you some case scenarios with initial tick presentation with PANDAS, and then share with you some stories mothers have and a documentary that was published to let people know about PANDAS worldwide with a few clips here.
Just started different motor and vocal tics.
What kind of motor and vocal tics?
Making different noises or humming or facial twitching, blinking.
He started with a wiping tick, so he would, it almost looked like he was itchy, so he would wipe his arms and his face and his head. One time she just started vocalizing nya, nya, nya. And it was just nya, 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 nya. And another breath and nya, 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 nya. And this went on and on.
They were so severe and frequent, people noticed. And people noticed right away. It wasn't something that she could hide.
I was in the change room, and there's a girl, and she was pointing out my tics, and it was embarrassing because I didn't really know what I was doing, and I wasn't trying to do it.
So that's the thing, is that all of a sudden parents notice these subtle tics that happen. Sometimes the infection is very minor, like they don't even notice, they don't always have clear strep throat symptoms. Be aware of that. And then some people, for whatever reason, get streptococcus, they're asymptomatic. Like they'll have no symptoms, they don't have strep throat, they just have acute onset, they check their blood and they have streptomycin antibodies off the charts. They're really elevated. So anytime you see, as a clinician, you see acute onset of tics or any kind of OCD behavior, you want to definitely check antibodies. And streptococcus is
Just
one of
started
them.
different motor and vocal tics.
Whoops, here you go. Here's the there's a great documentary that's available for everyone if you go online, Stolen Childhood. You can see it, and it goes into the presentations of families going through PANDAS. But here's a clip from a mother sharing her, there's a clip of this documentary, and then we'll go into some other clips of her as well.
One morning he woke up and came out of his bedroom and he said, "Mommy, I'm broken." And he started getting teary, and I said, "What do you mean you're broken?" And he just said, "I can't speak." "Nathan, what are you doing?" That he just had a complete speech block. He would grunt and kind of grimace. You could see like veins kind of popping out the sides because he was trying so hard to make words come out of his mouth. He would spit. It was terrifying. She started just having these insane, crazy meltdowns, just hallucinating. Not being able to have clothes on her body, but desperately wanting clothes on her body, so emptying out every drawer, pulling her drawers out, emptying her closet.
Marin.
Oh my God. I saw him walking in circles and humming, and doing this really kind of complex pattern walk in a circle.
Started to have an obsession with germs and being clean. And even when I'd say, but you just washed your hands, you're clean, he would say, I know I'm clean, but I don't feel clean.
But like
That's
frustrated,
the
like
difference.
screaming.
It just got worse and worse and worse, and he went from being happy and healthy and thriving to completely debilitated.
Just a complete tantrum of crying, and used to hit himself in the head with remotes or run into the wall.
My mom asked me to put on socks. I'd slam my head against doors, and I'd just get so mad.
And I remember thinking, like, he must be in more pain than he's creating. Because why else would he do it? Like, he's creating pain by hitting his head instead of putting socks on. The threads in the socks for him were worse than smashing his face on the ground.
Yeah, the hitting of the head, it was severe. It was really severe because you would say hit it so hard and said, sweetie, you're going to really do some damage.
We called our children's mental health agency and said, there's something wrong.
This is not my child.
So one of the key things is that PANDAS is not diagnosed common in the healthcare system. You have to realize, like, a lot of people that go through their training don't learn about these conditions, and that's changing with newer generation of healthcare professionals. But you know, when you look at this documentary too, you'll see they ask a question: how many of you were misdiagnosed? And they ask a whole room of parents, and every single parent raises their hand because they, you know, these have a neuropsychiatric acute onset expression. So it would only be logical to think of something that happened that caused an acute response. But if there isn't a clear pattern of an infection, they totally get misdiagnosed. And, sometimes these parents get accused of other things. It's terrible, but it's a real thing. Let me show you. This is a very touching story. So I want to share it with you.
So many things that are awful about pandas, but the worst thing, the thing that has changed the most is I'm someone who didn't think that I took life for granted. I almost lost my oldest son when he was 5 due to a misdiagnosed appendicitis. And that really turned my world around and made me focus on, thoroughly enjoying life. And now, looking back, it seems like I must have taken it for granted, because now every day is just, it hurts. It hurts. If the kids aren't hurting, I'm hurting. If I'm not hurting, he's hurting. If we're somehow numb that day, I'll get a text from my mom where she's a mess. It affects, it's a snowball. It's not just the child that is affected, although I have to believe that they are the ones who are affected the worst. I think about how painful it is for me, and then I look at my 2 little boys who did not ask for this and don't deserve this. And I think, if you guys can keep doing this, then I sure as hell have to.
Yeah, and I share this video with you because there's something that's really important that should be said with all these child disorders, is that the parents need to be in a support group. It's absolutely critical for parents are all impacted by this. The whole family's impacted by this. But having a support group to talk to other parents that they're all going through the same things can be very, very, very helpful. And, you see a child that has a developmental disorder or PANDAS or autism, you know what you see? You see a broken parent. You see a parent that is exhausted. They're now dedicated to their child, and they become super parents and raise up to the challenge and are looking for things to help them. So, these can happen at any time to any kid with a combination of variables we don't understand, but we know blood-brain barrier and loss of tolerance are part of it, but those aren't clear. Like you don't know a kid walking around has lost some blood-brain barrier permeability or things like that. They're not commonly no clear symptoms with it. So when you look at the criteria for PANDAS and PANS, this is these are what's the standard guidelines for diagnosing these patterns. So you can basically see OCD and tic onset, pediatric onset, episodic current of symptom severity, association with streptococcus for PANDAS, association with neurological abnormalities. And then here you can see with PANS, again, same thing, but it's not streptococcus. And then you have CANS, which is child acute neuropsychiatric symptoms. So the acute onset is before age 18, but basically they're all related to infections that then turn on these OCD, rapid onset, tic movement disorders and so forth. And there's different expressions for different people, but these are all symptoms associated with the basal ganglia. So the basal ganglia gets impaired. So when they look at percentage of frequencies of tic phenotypes in PANDAS and PANS, what they find that like a third of the percentage of tic phenotypes are vocal. And then you can see 30% are upper limb movements. And then 22% would be blinking. And then 15% would be whistling. So these are the most common tics that show up with PANDAS PANS. And then when you look at the frequency of neuropsychiatric symptoms, 26% suffer from anxiety. Enuresis is also common. 19% develop enuresis, 16% develop oppositional behavior to their parents and to people around them and their friends in school. The performance at school worsens, 16%. Phobias start to develop, 13%. Aggression start to develop, as far as the psychiatric manifestations. And in this study where they looked at OCD symptoms in 50 children with PANDAS and primary OCD and primary tic disorder, they looked at percentages. 67% had obsession with the contamination of their food. And then you can see 38% cause harm to self. They actually injure themselves. Harm to others, 42%. Compulsions, washing, cleaning, spitting was in 63%, repeating 58%. So there's a list of categories that you may see with those types of patterns. And let me just skip these ones not as important. And then as far as comorbid symptoms, 40% also have ADHD, 40% have oppositional defiant patterns, 36% have major depression. And symptoms, emotional liability is really one of the main ones, where they just have these ups and downs with their emotional behavior, changes in school performance, and personality change are really key ones. Bedtime fears happen about 50%. Fidgety separation anxiety is also very common, 46%. So those are the key things. So normally, when it comes to treatment of streptococcus and PANDAS and how it works is there's a strep throat, right? Sometimes it's clear symptoms, sometimes it's asymptomatic. There's acute neuropsychiatric symptoms, change of personality, anxiousness, aggressiveness, OCD behavior, tics, sensory problems, bedwetting, joint pain. They have elevated titers or positive strep throat swab. And then when strep with neuropsychiatric symptoms and the confirmation of strep come in, then the diagnosis of PANDAS is given. And conventional treatments are steroid, antibiotics, NIV, IG, plasmapheresis, and it works. And it calms down these kids' inflammatory symptoms in their brain pretty quickly. And that adds to the diagnosis. So if it's reoccurring, that's the issue when it comes to reoccurring. Then they remove the tonsils and there's a whole another clinical game here. The best scenario is, they have if they have PANDAS, they have an acute attack, they get treatment once and that's resolved. The scenario that's more common is that they have the infection once and they keep getting reoccurring infections and they keep having reoccurring flare-ups and autoimmunity, and they're dealing with this on an ongoing basis, which we'll get into that in a little bit here. So this was a paper that was published calling Evaluation of IV Immunoglobulins, IVIG therapy in pediatric onset neuropsychiatric symptoms, which is very effective. And they go on to say that conclusion in PANS, which we may associate with underlying immune dysregulation, sequential infusion successfully ameliorated psychological symptoms and dysfunction with sustained benefits for at least 8 weeks and up to 46 weeks. in a subset of subjects. In addition, baseline autoimmune profiles demonstrate significant elevations in the majority of subjects who require further evaluation, characterization, and study clarify the potential immune dysfunction by which PANDAS manifests and progresses. So you can see in the study where they looked at these subjects getting IG therapy, and you look at their neuropsychiatric cognitive impairment scores, they dramatically go down with these IG therapies. So what IV immunoglobulins do is these immunoglobulins compete with the circulating infection antibodies. So the circulating infection antibodies can't bind to the structure and tissues, so there's less autoimmune cross-reactivity that takes place. So the whole concept of IG therapy is that these immunoglobulins can compete with these other pathogenic antibodies. So, they show in this study that there's infusions, they get some benefits. Benefits can sometimes not be as great as time continues. But here's an illustration of children that were asked to draw a house before and after IV therapy. So before IV therapy, this was the child's drawing of a house. And immediately after infusion, they were able to draw this. Here, they were asked to draw people before infusion and right after infusion. And there's acute changes right after infusion. So this adds to the diagnosis actually being an infection causing cross-reactive antibodies when immunoglobulin therapy works. So as a clinician, not all of you do immunoglobulin therapy or even within your scope of practice, but if you see a parent that has a child with acute onset neuropsychiatric symptoms, you definitely want to make sure they look into this IG therapy. Unless you do it in your office, then this could be something that could be very helpful for them. Okay. Now, what you have to know about PANDAS and PANS is that for some people that it's chronic and it's persistent. And these kids that have PANDAS infection keep getting reinfected by asymptomatic carriers. And other times that these kids that develop PANDAS, the antibodies that turn on to their brain don't turn, that they still stay on even after the infection is gone. And then anything that triggers their immune response can continue to cause injury to the brain. So when they looked at MRI of children with OCD and tic disorders associated with streptococcal infection, they found some really interesting findings. So this was 82 subjects, 34 MRI of 34 PANDAS subjects and 82 healthy controls, comparing the two types of brain structures here. So they found that the basic ganglia enlargement, so that the basic ganglia enlargements we found among children with PANDAS are similar to the found with Stedman's chorea, this is a genetic basic ganglia disorder, and are consistent with the hypothesis of a selective cross-reactive antibody-mediated inflammation of the basic ganglia underlying the development of post-streptococcal OCD or tics in some individuals. These findings would not be evident with normal brain MRI without comparison to the volumes of healthy controls. Most PANDAS subjects will have normal MRIs unless there's significant demyelination with 5% sensitive signals. Okay, so let me point out what they're saying. So what they're saying is that these kids that have PANDAS, their basic ganglia is enlarged because it's inflamed. So there's injury and inflammation to the basic ganglia. But when they just have a normal MRI and the radiologist looks at it, it's not clear. It's only clear when they look at age-matched healthy controls. Just like when you look at neuroquant testing for people that have Alzheimer's disease and they have areas of their brain degenerate. Well, a person that just looks at the image, like a radiologist looks at the image, you just see, yeah, the brain's okay. It's just for that age, it's fine, looks okay, no big change. But the thing with neuroquantitative MRIs is they then compare the size of their hippocampus that degenerates in Alzheimer's with other people their age, and then they can really see the volume change to where it should be compared to people of that age group. So when they do that with PANDAS kids, they see that their basic ganglia is just swollen and inflamed. Now, some kids with PANDAS will actually have hyperintensities like demyelination in their brain, but in this study they just found statistically significant changes in the basic ganglia when they compared them to age-matched controls, right? And this was the study where they looked at MRI volume change after treatment with IV immunoglobulins. They actually saw the swelling come down before and after treatment. And here you can see it's not just swelling and enlargement, this is now autoimmunity, that the infection has actually injured the brain. So this is some of the patterns that show up with PANDAS. So what you have to be aware when you're looking at PANDAS is like in the acute pattern, they really should be getting antibiotics, IVIG therapy, even steroids to just calm down that inflammatory response. Steroids, some people may decide not to do it because it opens up the blood-brain barrier, but there's an immediate concern to stop the injury and inflammation to brain. So, you do whatever you need to do in that acute phase. So in the acute phase, there's treatment, but then there's recovery, and then they get another infection. And then there's recovery, and they get another infection. So there are people that are strep carriers, and for some reason, with families that get reinfections, they happen to test positive. So they're there, and these kids that have family members that are strep carriers that are asymptomatic. So asymptomatic subjects who have positive rapid antigen tests are considered strep carriers. So they have the infection, they're carrying it, but they don't have symptoms, and they keep reinfecting their child or their sibling or other people, and they keep getting this acute neuropsychiatric symptom that flares up. So you have a child that has acute onset of anxiety, OCD, harmful behavior, bedwetting, and so forth. Then they get through it, they calm down, and then boom, overnight, flared up again, like 3 months later. That sometimes happens with reinfection. And then at that point, if there's any type of reinfection, everyone in the family needs to be tested to be a strep carrier. But sometimes it's in school, sometimes it's in environments that they're in, which is hard to predict. And some parents actually pull their kids out of school and other environments because they're worried about that reinfection. Now, when you're looking at when you look at acute onset neuropsychiatric syndromes, there's a questionnaire, and these forms are all in your section of the course under evaluation and treatment. But you can go and use a form like this to objectify neuropsychiatric symptoms and rate them. So then you can use this tool as a way to monitor how the child is doing. And these can become useful tools because it really helps ask the important questions like anxiety symptoms. They scale and rate them: separation anxiety, general anxiety, irrational fears and phobias, panic, depression, emotional issues, aggressive behavior, behavioral regression, and so forth. And then you go through and have them fill out the form, and then that becomes your baseline. And then you can do treatment therapy or just observe, see how they're doing, and see if they get worse. So that's where these questionnaires become very useful. Now, as far as PANDAS panels go, the key thing is if you see neuropsychiatric symptoms and you see streptococcus positive lab testing or strep throat, then diagnosis of PANDAS is all you need. There's a panel that's used to diagnose the autoimmune reactions for PANDAS called the Cunningham panel. And the Cunningham panel is basically anti-dopamine D1 receptors, anti-dopamine D2 receptors, anto-lysogangloside or GM1, antitubulin, and then this immune marker, calcium calmodulin dependent protein kinase or CMK2, which is a stimulation test. And then they look at the panel and you see if these markers show up. So this is definitely a person who's developed dopamine autoantibodies that's there. Now you have to realize that some of these kids get infections and develop the autoimmunity, and the autoimmunity persists and stays ongoing. But these are structures in the basic ganglia that are commonly involved with this response. Now, this panel has gotten some criticism and some reviews, and let me show you a few of these papers so you understand what this is all about. And by the way, these are not all the target proteins. So there are many kids that will never show up with these biomarkers or a Cunningham panel, despite the fact they have infection-induced neuropsychiatric symptoms, respond to IVG, IV therapy in the acute phase. They just don't have these target proteins involved, and these lab tests are not perfect either. So be aware of that. So in this paper that was published in Journal of Neuroimmunology, they looked at the evaluation of the Cunningham panel in PANDAS and in PANS cases and patient symptoms. Here's what they found. This retrospective study examined whether change in patient pre- and post-treatment symptoms correlated with changes in anti-neuronal autoantibody titers and neuronal cell stimulation test, which is the calmodulin test, in the Cunningham panel in patients with pediatric neuroimmune psychiatric disorder and in PANS. When evaluated by changes in antibody levels, we observed an overall accuracy of 90% sensitivity, overall accuracy 90% sensitivity, 80% specificity, 90%, an area under the curve of 95.7%. So what they found was if the child has symptoms and has the antibodies, which not all children have with this panel, they can see some changes with those markers as their symptoms improve. Okay? So this doesn't tell you that it's the key method for diagnosis and accuracy. It just means if they have those antibodies, then you can use them as a baseline to see if symptoms are improving or not improving. But you can see those with just the psychiatric patterns and movement disorders. You don't necessarily need this antibody panel. And when other people have looked at these biomarkers for sensitivity, there's been some problems with this. So this is a paper that's also published in Journal of Neurology. And they did a study where they looked at all Swedish patients who had taken the Cunningham panel prior to June, which is 154 subjects, were invited, and 53 patients participated in the study. Based on comprehensive psychiatric assessment, the reference standard of diagnosis, subjects were classified as PANDAS or PANS, or neither. Prior Cunningham panel test results were collected from patient records, and new blood samples were similarly analyzed for the scope of the study. In addition, results were compared to healthy controls, and retest reliability analysis was performed. Conclusion: our findings identified a moderate correlation between change in CMK1 and change in symptoms varying in individuals with PANS or PANDAS. There's no indication that the Cunningham panel could be used to diagnose PANDAS or PANS. Our results also suggest that test reliability of CMK2 may be insufficient, and the Cunningham panel results are commonly elevated in healthy controls. It's not a perfect test. Because here's the problem: the PANDAS expert community, they put all this weight on this Cunningham panel. You should not do that. It's not that great. But if you have markers, then it helps confirm. But it's definitely gonna have lots of false negatives. Here's another study that was published, Journal of Neurology, and they go on to show that sensitivities of individual biomarkers in the Cunningham panel range from 15 to 60%, and specificities from 28 to 92%. Positive predictive values range from 17 to 40%, and negative predictive values from 44 to 70%. A majority of healthy controls had pathological Cunningham panel results, and retest reliability proved insufficient. Conclusion: the clinical use of this Cunningham panel diagnosed PANDAS is not supported by the study, meaning it's not as great as you may think it is. And then another paper that was published here, Open Access Translational Psychiatry. In conclusion, we found so-called positive value in Cunningham panel 86% of healthy controls compared to 92% in patients assessed for PANS and PANDAS. So what does this tell you? Well, let me just summarize this key thing, because you need to know about this. If you go to the labs that offer this profile, they cite this study. 92% specificity, sensitivity. They fail to mention it was with people that actually had positive and test up for the test, and then the negatives are number. They make it seem like it's a diagnostic window. So this I could tell you already, I don't know how to use the word, it pisses me off about the lab. Because this becomes pure marketing. Like, they're not even actually showing the actual literature and clarifying that they're nitpicking a piece of it and making it seem like it's the most accurate, specific diagnostic test, which to me, I have a problem with, right? So if you're from this lab, like, that is terrible. You should stop doing that. Be a professional lab and not a commercial lab trying to, make everyone convinced that this is an accurate test. This is not a perfect test. Like, all antibodies are not a perfect test. These are not the only autoimmune target proteins for PANS and PANDAS. There's lots of them not mentioned in this profile. So the key thing is there's limitations to this test. And just because a person doesn't have these autoantibody markers doesn't necessarily mean that the diagnosis of acute neuropsychiatric patterns are not there. The diagnosis of PANDAS is not based on these lab markers at all. It's really based on streptococcus infection, confirmation of streptococcus with acute neuropsychiatric symptoms. And same with PANS. There's an infection that it causes acute neuropsychiatric type symptoms. So anyways, don't put all your weight on this panel and realize the limitations of it. And it's not as sensitive and specific as people claim. And lots of healthy controls show up positive with it that don't really have issues, which then goes to lab false positive, false negative issues. Okay. Which occur with, any antibody type of pattern. So PANDAS, PANS, streptococcus infection, not streptococcus infection. Those are things that are not, well, actually, let me go back and say something else. The Cunningham panel, however, is still useful clinically. So what I'm trying to say is it's useful, but know the limitations. It can be a good test. If it does show positive, then you have autoimmunity against those target proteins. If you have antibody against those target proteins, that means the person now has autoimmunity, and that autoimmunity may persist. If they no longer have an active infection, but they still have autoantibodies, then that lets you know that there is an issue with potential ongoing activation of these target protein injuries, even when the infection is no longer there, but something triggers the autoimmune response. Okay, so remember with PANDAS, they have pharyngitis, they make these antibodies, they cross-react, they get IVIG therapy. Then the problem is, if it's reoccurring and so forth. So in the acute phase of PANDAS or PANS being not necessarily streptococcus, but any other infection, you guys, a lot of times you don't know what the infection is. And a lot of times there is an infection, and then a week later they start to develop PANDAS symptoms, or neuropsychiatric or basoganglia type symptoms. So in the acute phase of therapy, antibiotics if bacterial, because sometimes the PANS infection is not bacterial, it's viral. But IVIG therapy, steroids, those are things that are done in the acute phases. And then we also do tonsillectomy later on if it keeps reoccurring. So this is a paper that was published, PANDAS, a systemic review of treatment options. And here's what they include. There is paucity of high-level studies regarding this rare disorder, and no hard treatment recommendations can be made. Tonsillectomy should only be performed in those who are surgical candidates based on current published guidelines. Antibiotics are an option but provide uncertain benefits. Cognitive behavioral therapy remains a low-risk option. Studies that support the use of IVIG, however, more investigation needs to be prior to widespread. But basically, they're showing IVIG therapy can be effective. Antibiotics should be an option. Should be considered an option. But basically, in the acute phases, they will consider those, and if it consists, they may do removal of the tonsils, which really there isn't a lot of good information, published information on. And then functionally, in the acute phase, you really want to try to restore blood-brain barrier permeability. And remember that these pathogens have to cross to get into the blood-brain barrier. I mean, these antibodies have to cross to get into antibodies to cross-react. And a marker you can use for blood-brain barrier permeability is S100B. See if those levels are elevated. You can also measure things like blood-brain barrier protein antibodies and see if those are an issue. And you want to figure out why their blood-brain barrier is breaking down. So these are common mechanisms why the blood-brain barrier may break down. Sometimes you just don't know the cause. A lot of times it's just chronic intestinal permeability, food reactivity, lack of antioxidants. That may be a factor. But remember, something causes the blood-brain barrier to break down, and then antigen can cross through the blood-brain barrier. Then you activate the microglia. Then you get neuroinflammation, and then you trigger the autoantibody response as well. Now, when you look at the blood-brain barrier and what things you can do to heal it and what things are involved, elevated homocysteine, intestinal leaky guts, chronic stress, those are issues. Alcohol, obviously, is not an issue with children unless they're drinking it. So there's a body of evidence that shows regular physical exercise diminished blood-brain barrier permeability, and it reinforces antioxidant capacity, reduces oxidative stress. So movement, exercise seems to help the blood-brain barrier heal, because as you exercise, you increase blood flow and you increase your antioxidant reserves. Those things help to be supportive of the blood-brain barrier. They also know that lack of sleep causes blood-brain barrier breakdown, and then electromagnetic fields have actually been shown to impact the blood-brain barrier. So maybe they shouldn't be having their iPads right next to their head and face as they're in acute PANDAS response, because they show that these patterns do have an impact. Maybe if during the acute PANDAS responses and even further, you reduce their EMF exposures because they do impact blood-brain barrier permeabilities. Reduce the Wi-Fi router or use Ethernet cable instead of Wi-Fi as possible. Keep the phones in airplane mode. Use speakers or air tube headsets and EMF blocking devices, use laptops and battery, and so forth. So you can measure EMFs. You can go online, Amazon, and basically get an EMF meter and check the child's room and then reduce all the sources that are there. That seems to be very helpful. If you have to use devices, you can use devices that reduce EMFs. And these things really do have an impact. If you get an EMF meter and use some of these devices, it's clear when they're on these, pads or shields that they reduce them. And then acute stress has an impact on blood-brain barrier permeability, so you want to try to limit stress as much as possible for the child. And these are natural compounds that dampen neuroinflammation and may be supportive for blood-brain barrier issues. Resveratrol, curcumin are the ones I personally like the most to have effect there. And during the acute stage, as you're supporting the blood-brain barrier, you may want to improve the intestinal barrier. And with the intestinal barrier, we'll get into treatment, but studies show that in PANDAS, when they look at oxidative stress and intestinal permeability in LPS compared to controls, here you can see in PANDAS subjects that The markers for intestinal permeability and lipopolysaccharide elevation that occur with intestinal permeability markers like zonulin are all different compared to controls. So many kids that have PANDAS have leaky gut patterns, as the study has shown. And intestinal inflammation causes brain inflammation, and there's a link between blood-brain permeability and intestinal permeability. They both share zonulin, and there's high degrees of correlation between breakdown of one and the other. So, getting kids in the acute stages on a leaky gut diet where they're avoiding inflammatory foods like gluten, dairy, soy, corn, like GMO or foods or any foods that they have sensitivity to should be avoided. And then supporting their intestinal barriers like short-chain fatty acids, gluten, vitamin D, bone broth, probiotics, DGL could be helpful. You can use this as a typical leaky gut protocol, leaky gut diet, no gluten, no dairy, no processed foods, no fast foods, no fried foods, healthy amounts of vegetables, fermented foods, or you can be more aggressive and reduce nightshades and lectins. But removing inflammatory foods and healing the gut could be something that should be something to consider in PANDAS patterns. This was a study related to disorders of eating and food restrictions in generally PANDAS and PANS, and this highlights the point how this can maybe be very actually difficult to do. So sudden onset clinical significant eating restrictions are a defined feature of the clinical presentation of some of the cases of pediatric acute onset neuropsychiatric syndrome. Restrictions of food intake are typically fueled by contamination fears of choking, vomiting, or swallowing, or sensory issues, and texture, taste, and olfactory concerns. So I point this out to you because you might have a hard time changing their diet into a leaky gut diet, and you have to kind of find foods that work for them that they're not afraid of, and work with those fears as they change their diet. Support their microbiome. That's another key thing. And in this study that was published, we look at gut microbiota profiling and gut-brain crosstalk in children with PANDAS. Here's what they found. In conclusion, the study suggests that streptococcal infections alter gut bacterial communities, leading to pro-inflammatory state to the selection of specific bacterial strains associated with gut inflammation and immune stress responses. So you kind of see really that you kind of have a bidirectional thing. The infection itself can change the gut, the microbiome, but unhealthy microbiomes can contribute to the pro-inflammatory response that break down the blood-brain barrier. And here you can see like streptococcus infection, changing the microbiome, creating pro-inflammatory responses. Those things can potentially break down the blood-brain barrier. And when they look at the microbiome diversity index with controls in PANDAS-PANS patients, there's a huge difference there as well. So you see statistical significant changes in the microbiome diversity, alpha diversity scale here, control with PANDAS and PANS, control with PANDAS and PANS as well. And, natural antibacterial substances to help the microbiome, nutraceuticals support microbiome diversity, it's like short-chain fatty acids, just any source of fiber may be something that's very useful. And then lifestyle changes to really improve microbiome diversity, just making sure they get normal sleep, diverse meals, lots of different vegetable fibers and fruits. We do something called the microbiome mashup all the time, where we have family parents that just get a bunch of vegetables, put in a food processor, like 10, 15, 20 vegetables, and then just grind them all up. And then it becomes like a mixture of all these different vegetable protein fibers, and they just scoop a couple of those into something and get them down. And that's a way to really diversify the gut. So those are things that can be done. And then nutraceuticals to help just deal with any antigen-related issues, like things like wormwood, black walnut, inosilic acid, caprylic acid, have all shown to have natural antifungal, anti-yeast, natural antibacterial, natural antiparasitic properties. Those types of things can be some things to consider in the supportive phase. And then general improved immune function in the acute phase of PANDAS, which is like you got to make sure they sleep. Weighted blankets work great. You definitely want to consider looking at weighted blankets. They help raise serotonin and opioids during sleep. It feels like they're being hugged. It's much more comforting for them. Their anxiety goes down. They've done studies with autism with weighted blankets. They work great. Decreasing blue light. Remember, blue light also has EMFs. Stabilize your blood sugar, especially if they're waking up in the middle of the night. Make sure their blood sugars are stable before they go to bed. White noise machines make a consistent sound that helps people fall asleep as well. Physical exercise, improving the microbiome, restoring intestinal prepare, supporting T cells, supporting B cells. Any of these strategies may be something to consider in the acute phase management. Now, Once they get through the acute phase, you're hoping that was it. There's just an acute response. It was just an infection, that autoimmunity didn't develop, and they don't have reoccurring infections and other types of patterns that occurred. But some cases go into reoccurring chronic patterns. Then you have a whole different clinical window. And these are very common. So let's talk about this as well. So when you look at the normal streptococcus pattern, let's just stick with PANS for a second. Same would apply. Same mechanisms that lead to chronic apply it with PANS also, but let's look at PANDAS for a second. So get an acute infection, and they get another infection, and they get another infection. And when you're getting recurring infections, whether it's with PANDAS, with strep, or PANS, which could be viral etiology or another type of pathogen, there are 4 things you really want to be aware of. First of all, recurring strep infection exposure, usually from an asymptomatic carrier. So be aware of that. Okay? So if you look at these symptom profiles, when they get a reinfection with strep, I mean, first of all, they have increased ticks, right? Increased strep DNA titers. This antistreptolysin, increased ticks, serum white blood cells, increased or decreased, fever. Those are involved, and they may not even be bacterial, may not even be strep. They may be viral. They're the key features. They have fever associated with their normal symptoms. And, the strep tests are negative because it's not strep, right? So ASD, titer, antistreptolysin tick is negative, is elevated in strep infections, but not in recurring other types of pathogens. And then you can have neurological autoimmune relapses. They don't have fever. There's no fever involved with autoimmune flare-ups. So whenever you see fever, you're more likely to be thinking of like a pathogen. And if it's not strep, there's always possibility that it's a virus. And then glial cells can be primed, which is another key area. Like once injury happens to the area of the brain, those structures in the basal ganglia, and those cell structures change, anything that triggers an inflammatory response can activate their symptoms. So it looks like they're getting a reinfection. And what happens with a lot of cases is the parents keep having these reactivation patterns, and they keep thinking like they have strep again, and they have strep again, and they have strep again, and they give antibiotics. But you have to understand something about antibiotics. Antibiotics are anti-inflammatory. So antibiotics not only have antibacterial properties, but they reduce inflammatory mediators. And in the acute stage of using antibiotics, the symptoms go away. So let me give you a scenario. Let's say someone had an initial streptococcus infection, and let's say they injured their brain and got primed glial cells. Those glial cells chain and they became into a reactive state. And then something happens a few months later. Maybe they're extremely sensitive to gluten in milk, and they had something with really high amount of milk protein and dairy protein there. And then the next day they had a severe flare-up. Well, the parents now go, oh my God, it's another strep infection. They put them on antibiotics. And what do the antibiotics do? They reduce inflammation. So now they think, oh, they got a strep infection, but they didn't. It was primed glial cells that caused it. You go, you have another scenario. Maybe they now have autoantibodies against these target proteins. Something triggers their autoimmunity. Maybe they got a common cold that they're fighting, but they were able to get through. And at the same time, they had lack of sleep and stress, and their autoimmune disease flared up. And that antibodies against their DNA receptors, their dopamine receptors, and that flickered the response. And these antibiotics have an anti-inflammatory effect, so reduce them. And now they think, oh my God, my kids keep getting reinfections. And that's the problem. And every time they use antibiotics, they keep they keep destroying their microbiome and their immune health. And then you have these cases where parents keep thinking that their kids are getting reinfection, and they're really not. Because there's an autoimmune component and a prime glial component to this condition as well. So here you see misinterpretation of recurring PANDAS symptoms and infections, ongoing use of antibiotics, microbiome dysbiosis, impaired immune function is a pattern there. And then here you can see, clinical manifestation of PANDAS and PANS. Acute nervous, if it's from an infection, fever, abnormalities in white blood cells, abnormalities in T and B cells. But the key thing is fever, pathogen, etiology. See if they have an asymptomatic carrier, see if that's an issue. That's the key thing that you'll find with recurring actual streptococcus infections. And then if it's negative, then other pathogens may be an issue. Restore the blood-brain barrier, treatment to increase immune function. the other hand, if you have autoimmune trigger, you got to look for dietary proteins, chemical stress, lack of sleep, overtraining, and then try to reduce those factors. And if it's prime glial cells, anything that creates systemic inflammation can really cause neuroinflammation. So then all the concepts of trying to dampen neuroinflammation, microglial activity, flavonoids to change to an M1 state, ketogenic diet, intermittent fasting can all be strategies to help recover from a chronic PANDAS pattern. And remember, intermittent fasting helps promote autophagy to get rid of these prime glial cells. Ketogenic diet, ketosis, dampens microglial activity and neuroinflammation and flavonoids. This is a chart we used in the Carnegie Institute neuroinflammation course, but all the principles we talked about in the neuroinflammation course apply to reoccurring PANDAS because some of them have prime glial cells. So here you can see polyphenols that change microglial into an anti-inflammatory state, fatty acids, short-chain fatty acids, and different nutraceuticals that we went into in great detail in research in the course, but it's just a summary chart. So these can all be used with prime glial cells when they have an acute flare-up. But you have to realize they're not always recurring infections. So let's get into the management of basic ganglia disorders in general. So when you look at basic ganglia disorders, one possibility is, like we said, they get cross-reactivity, they get injury to the thalamus, they get OCD-type behaviors, tics, impulsivity, anxiety, and then these are related to immune dysregulation type patterns, and it's acute onset, and that's where you want to look at the antibodies as well. Sometimes it's not. Sometimes these autoimmune responses may have nothing to do with an infection, and they could do things like GAD65, which is found with celiac disease. So kids with celiac disease end up with antibodies, some of them do, to GAD65. And GAD65 is the enzyme that makes GABA. So you should also be aware of people that develop tic disorders and movement disorders that don't have PANDAS and don't have frontal lobe issues that may actually have celiac disease and gluten sensitivity. So you want to check for GAD65 antibodies. This is a paper that was published looking at GAD65 antibodies. This is GAD65 is the enzyme that makes glutamate to GABA. GABA is what you use to dampen the thalamus and the basal ganglia. And they lead to acute onset obsessive compulsive disorder. So for some children, especially those with celiac disease, they can get OCD type behavior. And a study that was done on gluten-free diets with children that had Tourette syndrome, pilot studies showed significant change and improvement with them. So there are some connections between gluten sensitivity. Gluten sensitivity may even cross-react with the basal ganglia directly itself. There's some early indications of that. But if you have tic disorders, movement disorders, you always want to rule out gluten sensitivity, even try just a gluten-free diet for a period of time. It actually should be gluten and dairy-free because gluten and dairy have similar protein structures. You always want to check the frontal lobe, make sure the frontal lobe is healthy. Remember, the frontal lobe activates the basal ganglia to dampen the thalamus. Those are key factors to look at. And if the frontal lobe is involved, like if you see focus, attention, concentration, planning issues, ADHD, and they have tics disorders and hyperactivity disorders, and it's not PANDAS and PANS because it's not acute onset, then try to get that frontal lobe healthy. And it's basically the same protocols we talked about for ADHD. Get them to do physical exercise, whether it's repetitive motor activity, integrated motor activity, focus coordination activities, get them to do cognitive tasks, find motor tasks, go, no-go, interactive games, and then really support that frontal lobe. Dopamine support, norepinephrine support, blood flow, and support the gut and give them fatty acids. So in summary, when we look at basal ganglia disorders, the frontal lobe, if it's not working well, if it gets fatigued quickly, can lose the ability to activate the basal ganglia. Basal ganglia can't inhibit the thalamus. Then it can't inhibit these limbic and motor loops, and we get these tics. Motor tics, vocal tics, OCD, anxiety, rage, anger, impulsivity, hyperactivity patterns that express, or we get cross-reactivity for the basal ganglia, such as with infections, or with things like GAD65 autoantibodies, with things like celiac disease, that can lead to inability to dampen the thalamus, and that's where these basal ganglia type disorders come out. So those are things you should be aware of. So let me highlight a couple key things as we finish off here. So the key things to remember: acute onset always is going to make it lean towards an infection. So if they have acute onset, tics, movement disorders, anxiety, OCD, that's when you want to look at infection. The most important ones to look at is strep. So see if they had strep throat, because that's a common pattern, and then look at streptolysin antibodies, serum markers for streptococcus infection. Sometimes they don't have any sore throat symptoms. They're asymptomatic, but if their antibodies are high, that can indicate a strep pattern. Other times you just can't find the infection. You'll see their white blood cells are off the charts. There's some kind of infection there. Their T and B cell profiles are abnormal. They have an infection. You can't find what the infection is. It's most likely in those cases some kind of viral infection, or they had like a common cold and then they had like PANDAS develop, or they get like foot, hand, and mouth infection, and the Coxsackie virus is now expressing into PANDAS, something like that. So those are really, your concern is, do they reoccur? Did this brain autoimmunity turn on? If they have ongoing neurological autoantibodies, like Cunningham panel, then you know that some ongoing neurological autoantibodies are there, and they may stay there even after the infection's gone, and now they're dealing with autoimmunity. And then also, if the injury was significant enough, some of these children end up with prime glial cells. And in those cases, it's not infection that's there. It's just the activation of the inflammatory response that's there. But they get confused as being infections because antibiotics help reduce symptoms because of their anti-inflammatory effect. So once a child develops PANDAS and PANDAS and has acute neuropsychiatric symptoms, be aware that it might not always be pathogen reactivation. However, don't exclude asymptomatic carriers. Realize that there could be autoimmunity as an underlying issue, especially if the antibodies like in the Cunningham panel are elevated, or any other kind of neurological antibodies are elevated. Like myelin basic protein or neurofilament or whatever that's not even on the Cunningham panel. And also be aware that some of these are just due to the inflammatory cascade, and you have to kind of go through your workup and make sure that's there, because constantly giving antibiotics may be an issue. And if it's not related to an acute onset, make sure that frontal lobe is healthy and make sure they don't have gluten sensitivity. Those would be some key areas to focus into as a clinician if you see basic ganglia type patterns. Thank you.